Good morning, everyone. On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meet. Different phases of ANCA vasculitis, lung, kidney, and nerves. Today, we have two eminent speakers, Professor Vikas Agrawal and Professor Vikas Agrawal will discuss neuropathy and ANCA vasculitis in next 25 minutes. After that, Professor Aman will discuss lung and kidney in patients with ANCA vasculitis. After these two talks, we will discuss interesting facts about ANCA vasculitis, particularly challenging diagnostic scenario and management issues in day-to-day practice. Regarding Professor Vikas Agrawal, he is MD Medicine, DM Clinical Immunology from SGPGIMS, MNAMS, and FRCP Edinburgh. He is Editor-in-Chief, Indian Journal of Rheumatology from last 3.5 years. He is heading Unit 3, Department of Clinical Immunology and Rheumatology, SGPGI Lucknow. He has more than 300 publications. His area of interest is scleroderma and other fibrotic conditions, mechanism of drug resistance in rheumatic diseases, and tropical rheumatology. Particularly, he is very innovative in diagnosing tuberculosis, and leprosy arthritis in rheumatology patient setting. Professor Aman Sharma is MD, FAMS, FACR, FRCP London, professor at PGI Chandigarh. He is member annual meeting planning committee, ACR from 2015 to 2018 for 4 years, an expert reviewer of ACR ULR classification criteria of ANCA vasculitis and Takayasu. He has received various awards from API. Important ones are Ravindranath Tagore Oration in 2019, V.R. Joshi Japi Award for Outstanding Referee, R. Subramaniam Endowment Oration 2015, Shurveer Singh Trust Visiting Professorship 2014, and he has received IRA Oration in 2015, Jaidus Oration 2011, IRA Young Investigator Award 2007, and he has also received Eminent Mid-Career Rheumatologist Oration in 2018 at CMC Vellore. He has published more than 432 scientific papers, and he has written chapters in 60 books. He is founder of Indian Vasculitis Registry, Indian Relapsing Polychondritis Registry, and he has written textbook of systemic vasculitis, psoriatic arthritis, spondyloarthritis, tropical rheumatology, urgencies and emergencies in rheumatology. With this background, I request Professor Vikas Agrawal to start the ANCA-associated vasculitic neuropathy.
Okay, good morning, everyone, and thank you, Dr. Panwari. It's always a pleasure to be with you, and I'll just share my screen for the presentation. Yeah, I hope it is visible to all. Panwari, is it visible?
Yes, sir. Yes, sir.
Okay, perfect. So, anti-neutrophil cytoplasmic antibody associated diseases are, we all know, necrotizing systemic vasculitides that affect predominantly small blood vessels. And when we say small blood vessels, we mean arterioles, capillaries, and venules. There are three main distinct systemic vasculitides in the term ANCA-associated vasculitis. Classical is granulomatous with polyangiitis, also called as GPA, and earlier called as vaginous granulomatosis. Second one is the microscopic polyangiitis, And the third one is eosinophilic granulomatosis with polyangiitis, uh, earlier termed as Sjogren's syndrome. All these vasculitides have clinical manifestations which are very variable, but predominantly they involve respiratory, ENT, and the kidneys. Peripheral nervous system is also reported in almost 50% of the patients who suffer from ANCA-associated vasculitides. Cranial neuropathies are rare and are generally limited to GPA. Various forms of nervous system involvement associated with these vasculitides are the peripheral nervous system manifesting predominantly as mononeuritis multiplex. And this condition is basically because of inflammation of the epineural arteries and the arterioles, which causes ischemia and subsequent damage to the nerve tissue. It may manifest in form of loss of muscle mass, as can be seen in these two in the photograph of the hands, and as a loss of deep tendon foot drop, as can be seen in the photograph on the right side. Central nervous system disease can also result, though rarely, in form of involvement of the meningeal vessels, and patient may present with seizures or generalized tonic-clonic epilepsy. Now, coming on to a brief epidemiological aspect of the peripheral nervous system involvement in ANCA-associated vasculitides. The prevalence is variable depending on the type of ANCA vasculitis. It is higher in eosinophilic granulomatosis with polyangiitis. Almost 60 to 80% individuals or patients may report peripheral neuropathy, followed by microscopic polyangiitis, where 50% up to 50% individuals can report peripheral neuropathy, followed by granulomatosis with polyangiitis, where up to one-fourth of the patients may report with peripheral neuropathy. The vasculitic neuropathy is most commonly in form of mononeuritis multiplex, seen in up to 70 to 90% of the cases. And rarely it can present with, or uncommonly it can present with symmetric or asymmetric polyneuropathy in up to 30% of the patients. The mononeuritis multiplex pattern may begin as asymmetric, but can gradually progress with progressive involvement to behave more like a symmetrical polyneuropathy and can present into a generalized sensory motor neuropathy. So, what are the symptoms which are associated with these patients who develop neuropathy in ANCA-associated vasculitis? The classical symptom is acute onset of pain, tingling or painful paresthesias. Sometimes they may present with weakness and sensory loss. Generally, all these manifestations are more commonly seen in the distal portion of the extremity. Predominantly, it is the lower limb which is involved first. The pain of vasculitic neuropathy is typically throbbing and aching in character rather than the burning sensation which we are classically taught as a manifestation of nerve involvement. Lower limbs are more commonly affected as compared to the upper limb, and the nerve which is more involved in the lower limb is deep peroneal nerve. And if we can all recollect our anatomy days, we know that deep peroneal nerve supplies the sensory sensations into the first web space between the great toe and the second toe. In the upper limb, the ulnar nerve is the most commonly affected nerve, but any nerve can be involved, and a patient may have sort of manifestations according to the nerve involved. Also, sometimes patients may present with sudden development of symptoms in a single nerve territory, which can progress over a day, few hours or days or weeks to involve the other nerves. If it is a motor involvement, then there is a loss of deep tendon reflexes, which may be reduced or absent. If patients are presenting a bit late or subchronically, then these patients may present with muscle weakness and atrophy, which may be mild initially but can become very prominent, as I had shown in the hand photographs earlier, which was very marked. Uncommon presentations are symmetric polyneuropathy from the onset. And pure motor neuropathy, though, has been described in few case reports, but are very, very uncommon or very rare. Incidence of cranial neuropathies is low, except for GPA, in which granuloma formation in the cranial region is common and the cranial vessels are involved because of that. So once we have a patient who has manifestations suggestive of maybe only the nervous system involvement in form of peripheral neuropathy or mononeuritis multiplex, or can have other organ manifestations and constitutional symptoms, then how to evaluate this person? The diagnostic workup, obviously, since symptoms are more uh, in the nervous system, we need to take up the patient for nerve conduction studies and electromyography. Why this is important? To define the distribution of the nerve involvement, whether it is focal, multifocal, or length dependent. Identify the functional modality, whether it is sensory motor or sensory motor. And to also characterize probable nerve pathology, because we can have an idea whether there is axonal degeneration or axonal loss versus demyelination. And also to select an appropriate nerve to biopsy if we require that for confirmation of the diagnosis. In the electrophysiological studies or in the nerve conduction studies, the axonal neuropathy can be sort of suggested by a decrease in compound muscle action potential as well as sensory nerve action potential, with preservation of motor and sensory conduction velocities and distal motor latencies. Also, there is preservation of H reflexes and F reflexes, with very mildly getting affected their latencies. Electromyography can demonstrate denervation, which can be recognized in form of fibrillation potentials and can be seen in up to 70% of the patients, or decreased recruitment in clinically weak muscles, or motor unit potential remodeling, which is consistent with chronic reinnervation. So generally, we tend to do both NCV as well as EMG together. Axon loss in an asymmetric pattern or in distribution of multiple nerves based on these electrodiagnostic studies is very much suggestive of a vasculitic neuropathy. Now, there are some issues with the nerve biopsy, though that remains the sort of the gold standard for diagnosing patients with vasculitic neuropathy. The technical expertise, which is only available at few centers, and disease being a very patchy process, still it may not be able to detect all the cases where vasculitis is there and the nerve tissue may not be showing the vascularity changes. So how to choose which nerve to biopsy? The nerve should be chosen based on clinically or neurophysiologically affected nerve. It has been reported that the greatest sensitivity for the biopsy has been reported in the tissue specimen of superficial peroneal nerve with concomitant peroneus brevis muscle biopsy. So should we be doing a nerve as well as a muscle biopsy together? That again is an issue which is contentious, and many centers follow this approach, whereas other centers only follow the nerve biopsy. The most specific changes in the nerve biopsy are seen in those involving the blood vessels passing through the or surrounding the nerve. Nerve itself may show changes of axonal neuropathy, but these changes may not be very specific for vasculitis. But axonal degeneration or multifocal asymmetric nerve fiber loss, which are characteristic of vasculitic neuropathy than any other neuropathies, can actually support a diagnosis of vasculitic neuropathy rather than being diagnostic itself. So we need to choose which nerve to biopsy. There are not many nerves which can be biopsied. Generally, sural nerve is the one which is biopsied most often, followed by superficial peroneal or superficial radial nerve. Now, when you biopsy a sural nerve, then you can biopsy either neighboring gastrocnemius muscle or even tibialis anterior or even quadriceps muscle. Or if you are biopsying superficial peroneal nerve, then it is advisable to biopsy peroneus brevis muscle as well. Why do we want to do that? Because muscle biopsy may increase the diagnostic sensitivity when it is performed concomitantly with the nerve biopsy. So what we expect or what makes a definite diagnosis of vasculitis on a nerve biopsy? This has been listed here in the right hand table. When you see inflammatory cells in the vessel wall and you see evidences of vascular damage, which can be in form of either acute vascular damage or chronic vascular damage. Acute vascular damage can be represented by fibrinoid necrosis, loss of disruption of the endothelium, loss or fragmentation of internal elastic lamina. You need special stains for that. Loss or fragmentation of smooth muscle cells in the media. Again, you need special stains for that. There can be demonstration of acute thrombosis or vascular or perivascular hemorrhage, suggesting that vessel wall has damage and the blood vessels have leaked out, or there is leukocytoclasia. These are for acute vascular damage. For chronic vascular damage, there may be suggestion of intimal hyperplasia, fibrosis of the media, or adventitial or periadventitial fibrosis, as well as chronic thrombosis with or without recanalization. Now, once you have these features on nerve biopsy, we are reasonably sure there is a definite vasculitic neuropathy. I'll show some of the photographs. So that is why I just briefly shared the histopathology of the nerve. Basically, there is epinurium, and within the epinurium, there is blood vessels, which are called as epinudial blood vessels. Then there is a perineurium where lies the endoneurium and the myelinated nerve fibers in this endoneurium, as can be seen in this particular diagram. So here on the figure A demonstrate acute vascular damage in the epineurial blood vessel of a sural nerve in a patient from a vasculitic neuropathy. The B figure is a blow up of that, and you can see that the vessel wall is totally damaged, and there is an intense inflammatory cell infiltrate within the vessel wall as well as surrounding it. The C figure here represents variable size. This is a basically stain for myelin. Toluidine blue staining is seen here, which represents myelin stain, and can be seen that there is a variable size myelinated fibers, showing that there is some loss of myelinated fibers. The D is electron micrograph of biopsy, showing that there is loss of uh, myelin, as can be seen in the figures which are representing the arrows. So all these features are suggestive of a vasculitic neuropathy. Many times it's not possible to visualize all these changes. Then can we make a diagnosis of vasculitic neuropathy? Yes, but then it is called as a probable vasculitic neuropathy. Here the nerve biopsy shows changes of axonal neuropathy without significant demyelination, and nerve biopsy shows features of perivascular inflammation and signs of active or chronic vascular damage, which is defined earlier, or perivascular or vascular inflammation, and with one or other of these following: vascular deposition of the complement or IgM or fibrinogen. Again, you need special stains for that. Or there can be a deposition of hemosiderin or asymmetric multifocal nerve fiber loss or degeneration. Prominent active axonal degeneration, or if there is myonecrosis or regeneration or infarcts in the muscle biopsy, which is accompanying the nerve, it can be suggestive of a probable vasculitic neuropathy. Whereas suggestive vasculitic neuropathy is seen where you have evidence of peripheral neuropathy on electrodiagnostic studies or clinical examination. And in addition, you have sort of a uh, biopsy which is showing perivascular inflammation of the cells, but it is not showing any features of vessel damage. Just to give you an idea, nerve biopsy taken from a patient with EGPA, there is infiltration of the eosinophils into the extravascular space in the epineurium in the figure A. In the figure B, there is seen that a packed blood vessel with eosinophils. Very easily, it can be made out that the eosinophils, which is stained red, are actually sort of clogging this small vessel. Also, the electron micrograph is showing figure C, where eosinophil has been located in the extravascular space of the endoneurium, which is marked by an asterisk, and there is degenerated nerve fiber, which is marked by an arrow. Now, these are some of the histological changes which are suggestive of vasculitis, but not confirmatory, where you see central fascicular fiber degeneration, that the loss of myelinated fibers in the center of the nerve fascicle are there, whereas in the periphery, the fascicles are preserved. Or it can be an interfascicular or intrafascicular variation in the extent of fiber loss, as can be seen in the figure B. There is a lot of variability in inter and intrafascicular nerve fiber loss. One need to remember that there are certain issues with nerve biopsy because not many nerves are there for biopsy. Generally, we tend to biopsy either a sural, superficial peroneal, or a superficial radial nerve. But it's always good if you can have a clinical or electrodiagnostic examination to choose or to guide us for the selection of the biopsy. Superficial peroneal nerve is usually combined with a peroneus brevis muscle biopsy. Sural nerve biopsies can be combined with gastrocnemius, anterior tibialis, or quadriceps. Concomitant muscle biopsy may reveal vasculitis not found in nerve biopsy because of sampling error. And it has been reported in various studies that muscle biopsy may increase the yield for definite vasculitis by 15% in patient with a final diagnosis of vasculitic neuropathy. One must remember that diagnostic sensitivity of a nerve biopsy for a definite vasculitis is around 50 to 60% only. One need to remember, just briefly, I have put it here, differential diagnosis. There is a whole long list of differential diagnosis of vasculitic neuropathy. And one must also remember that vasculitic neuropathies are very uncommon in real life scenario or in our clinical situations. So one need to consider all the common causes of neuropathies before considering a possibility of vasculitic neuropathy. Only in a given clinical scenario, one must consider the possibility of vasculitic neuropathy. And even in patients who have got evidences to suggest vasculitis, one need to look for non-vasculitic causes of neuropathy like drugs and others also. Nutritional or alcohol abuse, they all need to be considered. This is the data which has been taken from one large multicentric global study with the name of DC-WAS, which actually describes the phenotypes of different types of ANCA-associated vasculitis. And here, out of 955 individuals of ANCA-associated vasculitis, it was realized that patients with EGPA have got around 65% patients have got vasculitis. And predominant vasculitis across GPA, EGPA, and MPA was sensory motor. And it was also seen that patients with vasculitic neuropathy in these ANCA-associated vasculitis were less likely to have renal as well as GI involvement and also the eye involvement. May not be true for a given center, but this is what the data is. If you have vasculitic neuropathy, chances of having renal, eye, and GI involvement is less. A brief word about non-systemic vasculitic neuropathy, because it's a very close and very important differential diagnosis of uh, vasculitic neuropathy, or which we also can say or call as systemic vasculitic neuropathy. Generally, non-systemic vasculitic neuropathy is a single organ vasculitis of the peripheral nerves. It's typically multifocal or asymmetric, painful, sensory or sensory motor, predominantly affect lower limbs. And the important characteristic of this disease is that it is characterized by relapsing course of the disease in form of recurrent acute attacks. So it very well mimics like a systemic vasculitic neuropathy. The three different patterns of non-systemic vasculitic neuropathy are multifocal neuropathy, distal symmetric polyneuropathy, and an overlapping multifocal neuropathy, which can present as asymmetric polyneuropathy. Again, it is a distal predominant, but can also involve the proximal nerves, which is designated as a radiculoplexopathy or radiculoplexus neuropathy, which can be diabetic or non-diabetic. The diagnostic gold standard for non-systemic vasculitic neuropathy is again a vessel wall inflammation and damage identified on a nerve biopsy. It follows the same sort of diagnostic criteria. Important point to remember that non-systemic vasculitic neuropathy, though being only limited to the nerves, should be treated with an immunosuppressive agent, especially with the use of glucocorticoids with and without additional immunosuppressive drugs, which we use for systemic vasculitic neuropathies. One must remember that if you treat well in time, then these non-systemic vasculitic neuropathy do not spread to other organs, but around one-third of the individuals may experience a relapse. However, the long-term outcome is favorable, but patients may complain of chronic pain which can persist. So, in brief, NSVN is an acute relapsing multifocal neuropathy which can be slowly progressive without distinct asymmetries. So, one must not miss out on this entity also. Briefly, I'll discuss what is the pathophysiology of this ANCA-associated vasculitic neuropathies. It was realized from the animal studies when MPO was injected into the MPO knockout mice, they developed anti-MPO antibodies. And when the splenocytes from these mice were actually given to another group of mice which were racked to knockout, these mice developed severe glomerulonephritis, granulomatous inflammation, necrotizing arthritis, and pulmonary capillaritis. So clearly, it was seen that anti-MPO antibodies were actually pathogenic and were playing a role, which uh, causing manifestations suggestive of ANCA vasculitis. When these anti-MPO IgG antibodies were purified and were given to rag knockout or wild-type mice, it was realized that mice that received anti-MPO IgG antibodies, they developed focal necrotizing and crescentic glomerulonephritis with paucity of glomerular immunoglobulin deposits, almost mimicking like a ANCA vasculitis kidney involvement. So clearly there is a role for ANCA antibodies in the pathogenesis of ANCA-associated vasculitis. Also, it was seen that in patients with EGPA with neuropathy who were anti-MPO positive, eosinophils were seen to be attached to the endothelial cells of the capillaries, as can be seen in figure C and figure D. Also, patients who have anti-MPO negative EGPA but had neuropathy, it can be seen that the blood vessels were clogged with the presence of eosinophils. And there were a lot of eosinophils which were outside the blood vessel wall and also in and around the endoneuri. So in this paper, authors have actually suggested that patients of MPO positive ANCA vasculitis, that too of EGPA variety, the eosinophils are playing a role because eosinophils are actually causing destruction of the vessel wall by causing fibrinoid necrosis in MPO positive patients, whereas patients who are MPO negative, there the eosinophils are playing a role in form of vasculitic neuropathy by causing blockade of the blood vessels, leading to ischemia and subsequent damage to the nerves. This is an electron micrograph showing neutrophil which is adherent to the endothelium from one of the nerve biopsy specimen of a patient with ANCA vasculitis taken from a patient with MPA. And this is a sciatic nerve biopsy specimen from a patient with PGPA, where it was seen that eosinophil is actually causing exocytosis. The arrow indicates the granules which have exocytosed from the eosinophils. And we all know that NK antibodies, when they bind to the neutrophils, they cause its activation, where these activated neutrophils bind to or attach to become adherent to endothelial cells of the vessel wall. It releases a lot of pro-inflammatory cytokines, reactive oxygen species, and proteases. And in addition, releases propertine. And this propertine actually causes activation of alternative complement pathway, which leads on to activation of complement factor 5. Now, this complement factor 5 and its one of the products C5A, which is also anaphylotoxin, uh, is actually has been demonstrated to play an important role in the pathogenesis of ANCA vasculitis. So to summarize, there is ANCA, which are already there, which binds to neutrophils or other inflammatory cells, causes their activation, leading on to activation of alternative complement pathway, and also causing the neutrophils to bind to the or adherent to the endothelial cells and go into the extravascular compartment to cause damage. Also, the activated neutrophils secrete a lot of nets. Same is true for eosinophils, which also secretes a lot of nets to cause damage to the vessel wall. Neutrophils have also been shown to activate cascade of coagulation to generate thrombin, and eosinophils have also been reported to cause a lot of formation of ketosis, clogging of the vessels, and formation of thrombus by interacting with platelets, which all leads to damage to ischemia of the vessel and lead to damage to the nerves. In this case, we are talking of neuropathy. This is a brief overview, a simplified overview that there is some kind of an initiating inflammatory event where the neutrophils are primed by cytokines or eosinophils are primed by cytokines, and a lot of NK antigens are expressed on the surface of these cells, which binds to NK and causes their activation, release of various mechanisms whereby these cells lead to damage to the endothelial cells and vasculitis. Management of vasculitic neuropathy actually depends on the other organ system which are also involved within nerves. The general principle of management remains the same, like induction followed by a maintenance phase to prevent the relapse. In organ or life-threatening manifestations, generally glucocorticoids, whether high or low dose, depending on which school of thought you follow, in combination with cyclophosphamide or rituximab is recommended for induction. I think Dr. Professor Aman is going to talk in detail about treatment part. So I'll just briefly cover it up. Whereas mild or non-organ threatening disease can be treated with combination of glucocorticoids with methotrexate or mycophenolate or azathioprine. For maintaining the remission, again low-dose glucocorticoids with or without azathioprine or rituximab or methotrexate is recommended. Very recently, an expert consensus guideline has suggested to use of rituximab for maintenance of remission, especially in patients those who have received either rituximab or cyclophosphamide for induction of remission. Very recently, some new drugs have shown promise in form of mepolizumab, which is a humanized monoclonal antibody against interleukin 5, especially for EGPA. For futuristic therapies, avocapan, which is a C5A receptor antagonist, its efficacy has clearly been shown in clear and advocate trials. I'm not going to go into the details of that. Vilobelimab, which is a chimeric monoclonal antibody against the soluble form of C5a, is undergoing trials right now. And also, there is a very interesting trial going on with the use of abatacept in patients with ANCA vasculitis. The results are awaited. So the take-home message from my presentation is like ANCA-associated vasculitis. It's a systemic disease which affects peripheral nervous system frequently. So one must needs to be careful in examining the patients for evidence of peripheral neuropathy. Neuropathic features are generally mononeuritis multiplex-like. There are various many players which play a role in the pathogenesis of this vasculitic neuropathy, especially neutrophils and eosinophils. Immunosuppressive regimes are required for the control of damage to the nerves, and many times we may need the help of other specialties like neurologists, where they can help us out by uh, doing the electrodiagnostic studies for our patients. So with this, I will complete my presentation, and I will welcome any comments, suggestions, or questions. Thank you all for giving me the opportunity today. Thank you.
Thank you, Vikas. Thank you for excellent presentation on vasculitic neuropathy. We will discuss about some common queries after the Dr. Aman's talk. Now I request Professor Aman Sharma to deliver his talk on pulmonary renal ANCA vasculitis. Professor Aman Sharma.
Thank you, sir. It is always a pleasure to get in touch with you and interact with you, and for this very kind invitation on a topic which is very close to my heart. In the next 25 minutes or so, I'm going to share our experience and probably some carry home messages from these presentations. When you asked me to talk about lung and kidney and ANCA vasculitis, we did look at our own data from prospective data of 326 patients, out of which 167, which is around half of them, have had some form of lung involvement, and 34% of them had a renal involvement. And the pulmonary manifestations are in the form of cough, dyspnea, and hemoptysis. And these are the radiological findings like DAH, nodules, cavitatory disease, consolidation, and GGOs. So this can be an entire spectrum, and I'll briefly show you all of you a couple of examples of these cases. And in the renal involvement, it might be in the form of hematuria, proteinuria, or in the form of rapidly progressive renal failure. And to show the spectrum, this was a man from Haryana who came to the rheumatology clinic with joint disease. What he had was a red eye with pain and with these kind of skin lesions. And there was history of sinusitis and nasal crusting and nasal bleed. Initially, an X-ray was done, which were normal, but a CT was done, which showed a nodule like this, and a PR3 was in the light of the entire thing. A patient who was labeled as having arthritis, in fact, in actuality, turned out to be ANCA vasculitis, though there were no pulmonary symptoms. So this is one spectrum wherein there might be asymptomatic pulmonary nodules, kind of lung involvement in ANCA vasculitis. Another patient, a female, admitted under gynecology, 5th month period of gestation, with 3 months history of fever, cough with hemoptysis, dyspnea, hearing loss, nasal discharge, crusting, epistaxis, and inflammatory polyarthritis. Had anemia. Look at the platelet count, 6.09 lakh. This is our friend. Whenever platelets are high and in the initial part of workup, they always have a strong pointer towards an inflammatory disease like arthritis, like vasculitis. And as you can see, the inflammatory markers were very high, and PR3 was positive. This was the chest X-ray done, and you can see these kind of these are cannonball opacities, and you can see the CT, and this was studied with these cannonball opacities. This is a closer picture of the same cannonball opacities, and this was a systemic GPA with BVAS of 19. A 5th month period of gestation. The patient was, there was a dilemma what to do. The drugs which are used for induction, both rituximab and cyclophosphamide, are contraindicated per se as such in pregnancy. But when you are looking at the life of the patient, sometimes the gynecologists use the term that you take a decision disregarding the baby. And that's precisely what's done in consultation with the gynecologist. And fortunately, she made a good recovery, and she's still on follow-up. I think this is 3 or 4 years of follow-up. And child also didn't have any B cell depletion or any infections till immediately post-delivery until now. This case was eventually published as one of the images in the Lancet. And then this made us look at we did a systematic literature review of the pregnancy and ANCA vasculitis, and the entire cases which were reported in the literature at this time this was published was 110, out of which maximum were GPA patients, and as you can see, nearly 40% had renal involvement and 60% had lung involvement, and 62% the patients were diagnosed before pregnancy, 32 patients were diagnosed during pregnancy, and some were diagnosed in the postpartum period. And you can see the fetal outcomes. There were 20% had preterm, around 11% had abortions, and a quarter of them ended up in cesarean section. And all kinds of drugs have been used, and even cyclophosphamide and rituximab have been used in such scenarios during pregnancy with ANCA vasculitis. So all nodules may not be innocuous. Some might be, with the respiratory symptoms, as I showed in the previous patient. Another young female presented with arthritis, classical features of sinusitis, hearing impairment, fever, cough with expectoration, and had nodular lesions. She had already been started in ATP, as has been done in many patients previously, but and she was diagnosed as she had PR3 positive disease. She was diagnosed and treated with cyclophosphamide, but 8 days or 9 days down the line, she developed sudden breathlessness with these kind of shadows, which you can see, which were very overwhelming. And you can see this CT picture. This is quite suggestive of diffuse alveolar hemorrhage. And if you look at it, this is here where initial steroid and cyclophosphamide was given. And this is what happened after a few days. And you can see the fall in hemoglobin, more than 2 grams. And we thought that this is a lung hemorrhage. And this was when the patient was reinduced to cyclophosphamide. This was perhaps before the rituximab, Reva, and Trexivas trials were published. So this shows you that even if you've given a first cyclophosphamide, patients in the initial course might still evolve from classic nodular lesions, the kind that I showed you, to a lung hemorrhage, and you might have to re-strategize or maybe sometimes give a more immunosuppression and to salvage the life in such patients. Another interesting case, and this is another point which I wish to highlight, and which probably Dr. Banwari also wishes me to drive home, is that many times there are patients who are diagnosed as having interstitial lung disease. This was one such patient who now presented 5 years down the line with digital gangrene and sensory motor axonal polyneuropathy with high inflammatory markers. And we thought, could it be vasculitis? And yes, mp4 was positive. We were thinking on lines of microscopic cholangitis. Dr. Vikas has told you about the nerve involvement in different types of ANCA vasculitis and MPA. Surely it is more than GPA. And this was a nerve biopsy. We've talked about this, and I think you can see the vasculitis, the infiltration into the vessel wall, and this was really confirmatory for vasculitis. So this is again a book picture of interstitial lung disease, and in one of these reviews, it has been shown that perhaps ILD kind of manifestation is more common with microscopic cholangitis, and many times it is predating or pre-existing. So what it is proposed that what happens is that there are subclinical diffuse alveolar hemorrhage episodes which occur over a period of time, and eventually which lead on to interstitial lung disease. And in some of these patients, even we've seen where you will see that if patient has serial hemograms, they will see suddenly there would be fluctuating hemoglobin levels, suggesting that subclinical episodes of lung hemorrhage would have occurred leading on to interstitial lung disease. And if there is another either neurological manifestation or a renal microscopic hematuria and all that, always keep microscopic cholangitis as one of the possibilities, or rarely GPA if the sinus disease, etc. is there. So I did a literature. This was a review of 9 studies, more common in males. Herein it has been shown that DAH is more common in PR3 positive disease. There can be asymptomatic to mildly symptomatic to catastrophic presentations with fall in the hemoglobin. 1/3 of the patients might require mechanical ventilation. And the predictors of respiratory failure in one of the studies are the SpO2 FiO2 ratio less than 450, increased CRP, and increased neutrophil in the bowel fluid. So we are all interested in knowing what happens in the long term, and this was a study from two centers, David James, Cambridge, and from Czech Republic. The DAH criteria was taken according to the Plexivas criteria. We are all aware about it, and GPA again here was more common as compared to MPA, and it was first presentation in almost 86% of the patients, and majority had renal involvement. So unlike the neurological involvement, DAH generally occurs whenever there is a renal involvement. And X-ray in this study was showed abnormalities. Mark my words, almost 14-15% had no hemopsis. And the hemopsis not only in the last 24 hours or in the last 1 to 7 days, but in quite a substantial number of patients, it might be in the last 3 to 4 weeks, actually. And there might be drop in hemoglobin in by and large majority, with hypoxia and need for blood transfusions and need for ventilation, again in around 36%. So this is the outcome. The survival at 1 month, around 96%, 3 months, 83%. At the end of 2 years, 69%. But the most important thing, like Plexivas trial and one another study from Alex Peck's group, there was no difference in mortality between the group which received Plex versus the group which did not receive Plex. And the survival in this group, and these dotted lines are the the standard the confidence interval. The survival in this study was lower than the historical survival in another study. So it is a sinister manifestation to have. And another key point that I wish to highlight is many times the residents say, so there is only a streaky hemopsis in somebody who's had this kind of a clinical presentation. But that streaky hemopsis might be heralding a storm which might kill the patient. So it must be taken very, very seriously, because as you can see, then otherwise the outcomes might be very bad. So how are the lung functions? By and large, those who improve, in this large cohort, only 3 eventually were oxygen dependent, and 3 patients were diagnosed prior ILD, before diagnosed to have ANCA vasculitis, and 3 developed interstitial lung disease later on follow-up after having been diagnosed ANCA-associated vasculitis. Infections were common cause of mortality around in 1/5 of patients, and the other contributors were cardiovascular events and thromboembolic episode, which occurred in around 18% of the patients. There were no malignancies reported in this cohort. Another challenging case, a physician who was working in a TB sanatorium came with fever, dyspnea, classical presentation of ENT involvement, CT showing cavitating nodules, microscopic hematuria, and was diagnosed to have GPA, was started on steroids and cyclophosphamide, then developed an air fluid level. We initially thought it could be infective, gave antibiotics, didn't respond. Eventually, we had to give we had to withhold cyclophosphamide, but these lesions, they persisted. The patient developed pneumothorax, and we had to put in ICDD, and then started to have renal dysfunction. That is when we thought that this perhaps is disease activity, and was restarted on cyclophosphamide. Then again came with recurrent pneumothorax, for which a pleurodesis had to be done. This I'm showing the spectrum of lung involvement. Eventually came with fever, mucopurulent expectoration, and hemopsis. With infective workup was non-contributory. We ended up doing a open lung biopsy, which showed that it was only extensive granulomatous necrotizing vasculitis with elevated PR3 at that time, and patient had to be treated again as disease activity. Then again developed this fluid level. You can see this was also because of disease activity. And this story didn't stop here. Came again with fever, shortness of breath, sore throat, coarse craps, and this. But inflammatory markers were normal, platelets were normal, and he developed hypoxemia. The procal was normal, urinary was normal at this point in time, and these are the new shadows, as you can see. These are, and all of you who worked in COVID are aware that these are findings which we see in viral pneumonias, and this was H1N1, and had to be treated with high dose oseltamivir, and then he eventually improved. So even if the initial manifestation or some kind of a lung manifestation is because of GPA, the subsequents may or may not be because of the disease. We've had 3 patients two of whom had proven GPA on follow-up, had TB, and one had NTM infection. And in fact, one hemoptysis was because of aspergilloma in a cavity. So I think all these things we need to consider, and I'm sure we probably, these are on treatment are the patients where a repeat biopsy might also be warranted. If it is not fitting into a relapse, I think you will be more surer. The other manifestations are this: you can see the tracheal thickness, you can see the bronchial thickness, and also you can see the cavitating nodules. And the other manifestations can be again cavitating nodules with thick walls up to a centimeter with effusion. There can be, you can see a very beautiful air bronchogram. So it can be like a pneumonia with consolidation, angiocentric nodules, mass-like lesions. We have 3 patients who were initially labeled to have bronchogenic CA actually, especially if there is a bronchus thickened, trachea is also thickened, and there is a mass. So they were eventually diagnosed to have GPA, and one of the patients I saw yesterday has been on follow-up for more than 10 years now. The question is, if the upper airway symptoms are not there, and if there is only these kind of things, and you suspect that when we are not 100% sure, can radiology help us? We looked at our own data of GPA patients and sputum positive pulmonary tuberculosis patients. Well, yes, the size of the nodules, the location of the nodules, and if there is a consolidation, it goes more in favor of TB. And if there are parenchymal bands, that they also go in favor of TB. And if there is a mediastinal adenopathy, that strongly really goes in favor of TB. So these can help in differentiating. Why I want to tell you this is that we did a study. This was as part of one of the thesis of student, wherein pulmonary tuberculosis patients, we did an ANCA, and you can see they were only dot center sputum positive patients, in which around 7.8% had PR3 positivity. So even TB can cause PR3 positivity, and if they are the upper airway symptoms, renal, neurological, multi-system involvement is not there, we should always keep TB amongst the differential diagnosis. Now coming on to the different spectrum, this was a young male, small joint polyarthritis, rheumatoid factor positive, in fact was anti-CCP positive also, was labeled as RA, was given methotrexate, developed some cytopenias, was prescribed biologicals, came to PGI for second opinion. When I look at the reports, there was microscopic hematuria, there was nasal septal perforation, and there was red eye. So you can see this, there was evidence of scleritis, PR3 positivity. At that time, creatinine was normal, but 24-hour urine protein was 900 milligrams, and biopsy did show focal post-immune glomerulonephritis. So this was, even G. Wegener had described himself that half of the patients might have an arthritis which mimics like rheumatoid arthritis, and half of them will be rheumatoid factor positive. And unless we do look at the soft pointers, this patient had a septal perforation, was seeing a ENT surgeon. So we are likely to miss. And that's what I always tell my residents, that beware, once in your lifetime, you're going to see a GPA who you labeled or somebody else labeled as rheumatoid arthritis. We should always beware. So we looked at our data. This was a paper published many years ago. 51 out of 92, which is 55%, had renal involvement. 25% had advanced renal failure, which is creatinine more than 5.7. 41% had deranged renal function, but did not require dialysis. And 33% had proteinuria or active sediment. But one thing which I wish to show, that unlike the data from the West, our patients with ESRD were much lesser. So one, the prevalence is probably shade lower than what has been described from other groups, but also the renal outcomes of treatment are in, and that is the experience of Delhi and other places also. So I think that's what is different from us. And this was a Shankar's thesis, wherein we looked at histopathological classification and its impact on outcome. We know this is Burden's classification: focal, crescentic, mixed, and sclerotic. And as you can see, the outcomes were the worst, were the best with the focal, and the worst with the sclerotic. You can see the focal has the best outcomes and sclerotic had the worst outcomes. So histopathology at the outset can help in prognosticating these patients. And this again, the survival curves for you. The other thing which is commonly asked is ANCA status and the outcomes. ANCA positive versus ANCA negative patients. Majority, ANCA positive, ANCA negative generally because they don't have, many of them don't have other organ involvements. And in ANCA positive versus negative, they generally have more renal involvement, less of joint disease, less of neurological disease, and eventually, and this goes with what Dr. Vikas also said. And they have actually ANCA negative disease versus ANCA positive disease. ANCA negative disease has a worse outcome, contrary to what you might believe. And there are other groups also wherein the ANCA negative groups are having a worse outcome as compared to ANCA positive. So we all know about the Paxivas trial, and this was the steroid regime also, standard versus reduced dose, and we know that Paxivas didn't make any difference to the outcomes as far as end-stage renal disease is concerned, and low dose versus standard dose also did not differ. This is what we've started to do now. But people have always been debating that could doing a biopsy or looking at other parameters would have made any difference. This is a paper which was published in JASN earlier this year, wherein they've looked at a few parameters like age more than 45, which has got score of -2, MPA vasculitis versus PR3 positive, which has -5, MPO positive -2, and levels of creatinine. And if the score is more than 2, and if you do a biopsy, and they've also looked at the biopsy parameters, and if the score is more than 7, these are the patients which might benefit from doing a plasma exchange. I think although we always have thought that DH might be one condition where we will always do plex, but I think we don't have enough evidence. Rather, there are studies to the contrary for plex having a role even in diffuse alveolar hemorrhage. These are the mix-up of various guidelines. I don't have time to go into it, but this is published in the International Indian Journal of Rheumatology, September issue. You must all go through this because this gives you a one snapshot of comparison of all the guidelines. And whenever we are using rituximab, the common question which is asked is whether biosimilars are as effective as innovators. This is a published experience from us. Both in the induction phase and in the maintenance phase, the biosimilars have done as good as the innovators. So I would end by thanking Banwari sir again, and with the carry home messages that there are diverse lung and renal manifestations which dominate the clinical spectrum of AAV. Pulmonary manifestations vary from asymptomatic nodules to life-threatening diffuse alveolar hemorrhage. Renal manifestations also vary from urinary abnormalities like only microscopic hematuria to end-stage renal disease. Early diagnosis and appropriate treatment is the key to successful outcomes. And with this, I'll thank for your patient hearing, and I'll stop the share here, and I'll be happy to take any questions. Thank you, sir.
Thank you, Aman. Wonderful presentation, wonderful data, and we all are enlightened to hear you. And I think
and I was able to finish in time.
Yeah, no, I think everyone from audience is happy to hear you and Vikas. I have a few questions for you and Vikas. The first question is from Dr. Vikas Sharma. He has congratulated you. Excellent presentation, sir. My query is for a patient who presented with RPRF, DAH, and mononeuritis multiplex. She had anti-MPO and anti-GBM antibody dual positivity. We gave her a steroid pulse and cyclophosphamide as per UVA's regime, 3 pulses till now, and 6 sessions of plex. Her creatinine has stabilized at 2.3. Initially was 5. Should we continue IV cyclophosphamide regime or do something else also in view of anti-GBM antibody? Yes, Aman.
Thanks, Vikas. Sorry. Thanks, Vikas. Vikas is our student at IGMC Shimla. He has started a new section of rheumatology in IGMC. And I think because there is no confusion, you must continue cyclophosphamide. There are dual positive patients. Good that you gave plex and the creatinine has come down. So part of which tells us that unlike in anti-GBM disease, where many times the creatinine may not come down, that's what we know. But if it goes at a very high level, but there is no confusion. You have to treat both and probably continue cyclophosphamide, complete the UVAS regime. And although I know it is an MPO positive disease, then you have to switch the patient to maintenance. You can choose between rituximab and azathioprine, whichever suits you, because it's not PR3, it's MPO. But by and large, my choice would be to give 6 pulses of cyclophosphamide and then perhaps give rituximab 500 milligrams every 6 months and see what happens.
Vikas, anything to add?
No, I think that's perfect because induction is important, and already we are on path of the cyclophosphamide based regime. So he has to complete it, and after that, because anti-GBM likelihood of relapses will be high,
Yeah.
so they have to choose very carefully for the maintenance part. And rituximab is a very good choice for maintenance.
Rituximab with low dose steroid or only rituximab?
No, rituximab with low dose glucocorticoids.
So basically, you would like to continue either 5 milligram or 7.5 milligram steroid also along with rituximab.
Yeah,
Yes,
Aman.
sir. Sir,
Yeah.
actually, if you look at the data carefully, even from the RAVE trial, if you look at the international practices, the Americans tend to, the North America tend to stop steroids at 6 months, whereas the Europeans still continue till year and a half, many of the centers. And I think if you even look at the RAVE trial data, the relapse rates were higher. Probably the one reason which was thought was that perhaps the steroids are stopped at 6 months. So the thing is that although you can come down on steroids, the general dictum is that you will have to use some steroid, maybe 5 milligrams for at least year and a half. That's what we do. And that was our hypothesis in the paper in a reviewer's comments, that we continue to give 5 milligrams of prednisone, because if inadvertently, if it is stopped, you'll see the patients coming back with bad relapses.
So basically, when you maintain the remission part with low dose steroid and rituximab once every 6 months, 500 milligram, do you give PCP prophylaxis in this group also?
Yes. We give to both Ceptran prophylaxis, both for rituximab and also for cyclophosphamide. It's such a innocuous drug, keeps away PCP, keeps away urine tract infections, upper airway infections, and also there is a nebulous evidence in favor of staph colonization, which contributes to GPA relapses also. So multiple positives for continuing Ceptran.
So basically, 3 drugs like low dose steroid,
Yes.
and then the Bactrim DS and folic acid. These 3 drugs will be for long-term treatment.
Absolutely. And so calcium and all that, for if you are giving steroids and all of that, we have to continue.
Yeah. Another question from Dr. Bhupendra Vaishnav. Bhupendra is at Jaipur. Experience with anti-CCP positive rheumatoid arthritis developing ANCA-associated vasculitis. Can we label as overlap of RA with AAV? If patient is not responding with one immunosuppressive, how early we can repeat same or other immunosuppressive with severe organ involvement like DAH?
I think both are very, very pertinent questions. This is more a question of semantics. At least we have 2 or 3 patients where the patient had an iffy kind of a joint disease. There is, besides the patient that I showed, there is a lady who comes from Bombay who also had rheumatoid factor positivity and low titer anti-CCP positivity also, but only had a few joints, 2 or 3 finger joint involved, and was given steroids and methotrexate, was good for some time. Never had erosions, never had deformities, never had a disabling kind of arthritis. 6 months down the line, she developed a pyoderma gangrenosum kind of a present and extensive GPA manifestation. And if you go history and look at, history is always a big teacher. If you look at what Wegener said, he said 50, there was no anti-CCP at that time. He said half of my patients are going to have rheumatoid factor positivity, and half of they might have had, some of them might have had anti-CCP positivity also. How do we know? So I'll probably think they are only GPA, because no erosions, early onset disease, few joint involvement, milder kind of joint involvement. I'll probably see that as there is an autoantibody positivity in a much sinister disease. In any case, I'll probably keep it that. Although jury is still out, we can label whatever we wish to. But I think if we are using rituximab in maintenance and keeping them on long-term follow-up, the answer might come that if you stop rituximab 3 years or 3 years for 4 years down the line, and patient develops a joint disease and doesn't have any other manifestation of ANCA vasculitis, that is where the answer might come. Otherwise, we may, because RA will not disappear if it was RA overlapping with ANCA. That's how I will see it. Whereas then you might get that answer clearly and develops erosion and all that. Till that time, I'll probably call them as GPA only. Regarding your next part of the question, the common mistake that many people do is that in their anxiety to treat aggressively, many times we end up combining cyclophosphamide with rituximab, which in my opinion should not be done. because if you look at Mark Little's data from Dublin, the most important contributor to mortality in the first year of disease is infection, more than 1/3. And the most common contributor is high dose steroids. And if you combine rituximab with cyclophosphamide, you just have to be patient. In the early part, neither rituximab nor cyclophosphamide is going to work. Rituximab is going to take 3-4 weeks or more. Cyclophosphamide is going to take at least 2 weeks, IV pulse cyclophosphamide also. So what is going to help in the beginning is supportive care, ventilatory support, high dose steroids. They are going to act in the initial part by the time the rituximab and cyclophosphamide start to work. So we have to be just patient. We have had many patients of GPA, and the one that I showed also, Manju Gupta, she was given rituximab because she had a relapsing disease, PR3 positive disease. Initially was induced with cyclophosphamide. We only gave rituximab. She was on ventilator initially for a week, and then she was requiring oxygen. Now she walks to the clinic with only one drug. That's the lesson that we've learned. Don't be in a hurry to combine two, because wherever we've had very bad outcomes with infection. Don't combine unless patient has a very bad disease, multiple relapses. There you combine. If you have to combine, perhaps combine either a drug like methotrexate or azathioprine along with cyclophosphamide if you require at some stage. Don't combine both cyclo and rituximab. I mean, that's my personal opinion. I don't have any data, but I'm fearful of infections.
Vikas, anything to add?
No, I think Aman has said everything what is required. Just want to add, actually, yesterday I saw a patient of ours being labeled as GPA, and this guy actually presented to me with dactylitis of all the toes of the feet, both sides, as well as thumb dactylitis on the right side. And he's a businessman. So he said, Ki sab, I'm not able to walk for last 2 to 3 months. I looked back at his file, it was mentioned as GPA. Now GPA coming with dactylitis with a normal creatinine, no uric acid high. So what was that? I looked back at his file. I asked him questions. Fortunately, he was carrying an X-ray of the pelvis. I don't know why it was done, but somebody outside actually evaluated him in Delhi, and that showed bilateral grade 4 sacroiliitis. And he said, yes, he did have low back pain in the initial part, but for which he was never bothered and he never consulted anyone. He came to us with a diffuse alveolar hemorrhage and peripheral vasculitic neuropathies about 5 years ago. And now this time he is on rituximab. He is maintaining his remission for GPA, but now he has a flare of probably ankylosing spondylitis. I asked, he has a family history very much. His son has got ankylosing. Some of the sisters have got ankylosing. So, the question has been asked about anti-CCP positive, and as Anupam has very clearly mentioned that even in the original series of Wegener's, there were a lot of patients who had disease mimicking like rheumatoid arthritis. So it's just a matter of semantics whether you call them as an overlap with RA with GPA, and maybe here in our case maybe an ankylosing with GPA. That just remains the same. You just need to treat accordingly. So yesterday I was in a very perplexing position whether I should be asking him to take something for his dactylitis. So I had asked him to come on Tuesday so that I can read in between these 2 days and may suggest something. So any suggestion, Aman, for this particular patient? Should I go ahead and try out with anti-TNF? He has received his last rituximab in February this year.
So where all? I'm sorry, I might have missed something. Where is the GPA active now?
No, GPA is in remission. So he received a maintenance dose of
one only suggestion that there was a WEGENT trial. Even if you choose to give anti-TNF, don't give etanercept, because there is a negative study which showed that etanercept doesn't work. In refractory cases, there is some literature of using of Remicade. If you have to use, perhaps use Remicade. Or the other drug which might be good academic, they would be tofacitinib. There are reports of people have used tofacitinib in GPA, some of the anecdotal reports, and tofacitinib is also effective in SPA. So either Remicade, there are reports of use of infliximab in ANCA vasculitis, although it's only case reports. I would probably use Remicade, infliximab over, shouldn't be using the brand name, infliximab over etanercept.
Right.
I'm sorry for my use of
No, no, it's perfect, perfect. Just want to share because you mentioned about tofacitinib. This is just an anecdotal experience which I am sharing.
Yeah,
Two patients of scleritis, refractory scleritis, not responding to cyclophosphamide and even rituximab, has actually responded very well to tofacitinib. Just wanted to share. This is just in last 6 months we had seen that scleritis has. The patient told us that "Saab, pehle kyun nahi diya?" He said it was not available.
Hmm.
So maybe you can just see and maybe you can have more experience about treatment of scleritis part also. So maybe
Yeah.
this is just for the
Use
listeners.
tofacitinib.
Another thing is, if you remember, Vikas, previously we used to think that ANCA-associated vasculitis or GPA patient usually presents with aggressive disease. But if you see the literature, good number of patients, up to 20% of the patient, they can have mild disease, they can have only fleeting arthralgias or arthritis initially, they can have chronic sinusitis, intermittent scleritis, and then even mildly elevated ESR or CRP. We usually treat them as palindromic RA or rheumatoid arthritis because rheumatoid factor and anti-CCP is positive. And when we do not go for ANCA or ELISA for PR3 or MPO, we miss the diagnosis. Later on, after a few years, they develop another symptom like kidney involvement or pulmonary involvement or refractory symptoms. Then we investigate further and we find that this patient has ANCA-associated vasculitis. This is well mentioned in the literature. So this might be the cause that methotrexate sometimes suppresses the low-grade inflammation and causes remission or partial remission in these patients.
Sir, one story I always tell all my residents, which if you allow me, I'll tell here. There was a patient, Balmati Devi, she used to come from Banaras. And this was one of the earliest patients that I saw. 1988 till 2002. I'm giving you our own. The lady had only sinus disease and some joint disease. Biopsies done showing a granuloma. Limited disease going on till 2002. I just finished in half a minute. Developed a systemic disease in 2005. Cardiac involvement, cardiac arrest. Then had an advanced renal failure in 2010. So these diseases, they initially for good 15 years, it was 14 years, it was only confined to sinuses and some joint with 3 biopsies showing a granuloma, then developing into a systemic disease, and eventually she died in 2011.
Yes, absolutely. So another question from Dr. Avinash Jain. Avinash is from Jaipur. We all know him. How common are arterial thrombosis and ANCA vasculitis, particularly GPA, in your experience? We have seen, and there is literature on venous thrombosis in ANCA vasculitis.
Yes, I think we are looking at this. Pratik is our resident is looking at this data. Gangrene as such is not very common. In the recent times, we've had 3 patients admitted with peripheral gangrene. We've had gangrenes in the past, some toe gangrene, something like that. One of the patients I showed in the presentation also. But we've had more of such patients in the recent past. So the question which was playing into my mind was whether a COVID epidemic and thrombogenesis associated with COVID epidemic had anything to do with it, because we are seeing more peripheral gangrene along with ANCA vasculitis now as compared to what we saw in the past. But till such time that we analyze our own data, Shankar is looking at the venous thrombosis. Offhand, I remember, I think we've seen at least 9. We've seen axillary vein thrombosis, venous thrombosis also. And I think the other resident is looking at the arterial data. Once we have that ready, I'll share with you, Avinash. And I don't have the numbers because we've not looked at the data.
I think, Aman, what Avinash is asking is deep venous thrombosis. I have remembered this patient, Avinash, and I have already discussed this. This patient had DVT.
Yes, sir.
DVT also. So, and if you see the literature, around 6 to 7% GPA patient can have DVT. Because what is your experience?
Yeah, so we do see patients with finger or toe gangrenes coming up with GPA or MPA. I don't recollect that they develop any kind of thrombotic event at other sites. We attribute generally to vasculitis, active vasculitis as the presenting manifestations. Venous thromboembolism we have seen in patients with EGPA. I can recollect some 2 or 3 patients who develop even pulmonary embolism also. But not in GPA as such. I don't recollect offhand in my mind. But it's reported in literature that all these patients can actually develop predominantly venous thrombosis.
Yeah,
That can cause vasculitis.
I remember this patient because Avinash asked me, patient has DVT, he was in dilemma to give rituximab or not in that particular situation. That was the thing. That's why I remember.
So I think there is literature, as you said, we've also seen, and I think Pratik has just sent me an answer that's around 15%. That includes the splenic infarcts also. But we'll look at the peripheral gangrene, arterial gangrene, and get back.
Okay. The next question is from Rashmi Ranjan Sahu. A young male with polyarthritis of 3 months duration, rheumatoid factor anti-CPA negative, presented with acute bilateral NSIP, no DAH, MPO, ELISA, and immunofluorescence positive. Just summon your case. High titer.
Treat like ANCA vasculitis. This always was microscopic cholangitis.
Yeah.
We have 6 or 7 patients of like that.
Yeah.
And, it's not uncommon.
Yeah.
It's not uncommon.
So the message is whenever this kind of presentation in early disease, like this is the presenting manifestation, and if you find positivity of ANCA, you treat that.
Yes. Otherwise, they'll develop renal failure and come with advanced renal failure later on.
Yeah. The next question is from Dr. Bhupendra Vaishnav. Vikas sir, when to stop treatment in non-systemic vasculitic neuropathy when in remission and when in remission? These are the 2 questions.
Yeah. Remission is easily defined that patient has improvement in the symptom and there is no worsening in any other measure. Around at least 6 months of treatment patient has received, and so this is how you can. There may be different definitions of remission, which somebody may say that we need to see whether the electrodiagnostic studies have become normal or not. That can also be taken as remission. But once you feel like patient is in remission, then generally you try to continue treatment for another, say, 12 to 18 months. And when I say 12 to 18 months, preferably glucocorticoid should be stopped 6 months before you finally stop the steroid sparing agent, whatever you are using, or you call it a immunosuppressive agent. So I will say that around 2 years of remission should be there before you actually stop all the treatment for treatment of NSVN. Otherwise, this is notorious for relapsing course. As I mentioned, 1/3 cases, they do relapse very frequently.
Because do you advocate NCV studies when patient is in remission and you are tapering the immunosuppression?
Generally, see, in our center, it's very difficult to get an NCV for a patient for a diagnostic issue. So to chase the neurologist to get it done for prognostication or in follow-up is again a mammoth effort. You need sort of one-to-one equation with the neurologist. Unless it is a part of some study, it will not be done. That is for sure. But besides that, generally we don't do. We clinically evaluate patient, and if patient is symptomatically or on clinical examination, like the motor weaknesses have improved and there is preservation of the reflexes or reflexes have come back which were lost earlier, we generally don't go for NCV studies. But if somebody has access to nerve conduction lab, which I was actually having that facility with me when I was in Chandigarh at Government Medical College Sector 32 Hospital, where the lab was with us, where there we were actually doing for all the carpal tunnel syndrome patients after injection of the glucocorticoid every 3 months. So, but they probably can help. And if you look at some of the literature which is available, people have reported like that. After having benefit, the nerve conduction studies do show that the conduction abnormalities have recovered. But there is no such data which can suggest whether we need to do nerve conduction studies routinely in follow-up of these patients.
Now, another question is because, as you told, painful, rapidly progressive, predominantly lower limb neuropathy when patient presents with systemic features, we should think of vasculitic neuropathy. So, and you have seen a lot of patients of leprosy neuropathy also. Can you give some tips to diagnose, not to miss this leprosy neuropathy from this vasculitic neuropathy?
Yeah, being an Indian, I think leprosy should be known to every one of us. And in this part of the world where we are in Lucknow, which is eastern part of, or you can say eastern part of UP and going on the borders of Bihar and subsequent areas towards West Bengal and Odisha, this is has got the highest endemicity for leprosy in the world. So there are people who can present to you with either various rheumatic manifestations or including symptoms suggestive of vasculitis, and we have seen like those cases here. Generally, leprosy neuropathies are sensory; they are not motor. So that is one big difference which can actually help in clinicians in picking up cases of leprosy. And one should develop a habit of just putting a hand or finger at certain sites, like feeling or palpating the ulnar nerve, just having a look at the greater auricular nerve. It doesn't require even a palpation. Visual inspection is good enough. Or just putting a finger on the common peroneal nerve or a sural nerve can actually give you a very good idea if the nerves are thickened that this could be a patient who might be having leprosy. We have done this error. We have treated patient with rheumatoid vasculitis, and when the nerve biopsies were done, it turned out to be leprosy, something which was totally curable. Otherwise, we would have landed up with so many complications for the patient. So this is one thing which one needs to remember. And leprosy can present in any form. It can present with mononeuropathies, it can present with polyneuropathies, which can present with mononeuritis multiplex. You just need to have a high index of suspicion. And if you are careful enough, you can look at the ear pinna, if there is any suggestion of any infiltration into the ear pinna or some skin rashes, which can be even macules itself. But if you just check for sensations over there, you can pick up leprosy very easily. Aman will remember when we sort of delivered that presentation in ACR in 2018, I believe, and the Americans were coming and saying that we are ashamed that we don't know how to palpate a nerve, because I presented 4 cases of leprosy, and every time the diagnosis of leprosy was picked up clinically based on clinical examination. The nerves were thickened. So they said, Kisa, we have never palpated the nerves. So I said, it's so easy.
Yeah.
So being an Indian, and we have got
And
highest
more
endemic.
so, not only Indian, actually, when we proposed that session and made a draft, the leprosy was reported from more than 100 countries, more so in the biological era. And not only
Yeah.
for us, it is for important for everybody who uses this arsenal to be aware about this entity all across the globe. For the residents who are passing out and probably going abroad, they must also be aware as much as we should be.
Okay.
Absolutely right.
Aman, a quick question from you.
Sir.
Rituximab you give for induction and maintenance of ANCA vasculitis.
Yeah.
And do you monitor immunoglobulin levels before giving rituximab every time?
Yes, it is very important. As a protocol, we do a serum IgG levels every time. Because one-off majority, by and large majority, they are normal. But in one-off patient, you will sometimes end up having very bad infections, difficult to treat infections. And from knowing from the both from patient's perspective and litigation perspective, it is better to do it. It's done easily, done the same day. And I think there are guidelines now how to manage hypogammaglobulinemia before you give. I think it should be done. There is some suggestion that it is probably dose dependent, and you give more rituximab, there is more hypogammaglobulinemia. So I think it is always better to do it. We do it routinely. I mean,
how common is hypogammaglobulinemia with rituximab in your?
I remember 2 patients developing very bad infections.
Yeah.
One was from Gujarat. I think the girl who was sent by Shabir to us, who had a tracheostomy in situ. There was another person who developed severe infection. So out of a large cohort, there are only 2 or 3 that I can remember. But it's something which is just, it costs us 300 rupees. So as a matter of protocol, we get it done every time and then give rituximab.
Another question is, suppose patient develops normal immunoglobulins after basically withholding rituximab for 6 months. Do you re-challenge these patients?
We haven't had so many in those numbers for
Okay,
really
okay,
us
okay.
to have that kind of experience.
Okay.
But theory says if you have less than 3 or you have had recurrent infections, it would make sense to give IVIG and then give rituximab.
Okay. Another thing is, Aman, early diagnosis of GPA, suspected patient presents with chronic sinusitis, sinusitis and scleritis and oral ulcers, some hearing impairment. How to investigate this kind of patient to see the extent of the disease and to see the severity of the disease?
Very good question, sir. If there are no pulmonary symptoms, the two things which must always be looked for, one are the lungs and the other is kidney. So you will do a urine analysis, you will do a renal functions, which are done as a protocol. Everybody will do it. Besides the chest X-ray, I always do a CT at the baseline. Why it helps is many times the X-ray is normal. If the patient comes with iffy kind of a suspicion of a relapse and you do an imaging like chest CT later on, and if you haven't done something in the baseline, if say, for example, there were 5 nodules in the beginning, which were not picked up, small nodules which are not picked up on the X-ray, and your patient is doing fine, there are some sinus symptoms and some ESR going up and you're not sure, you do a CT at that time and you pick up 3 out of those 5 which were present in the beginning. Rather, the patient is getting better, but you will give a reinduction because you presume that the X-ray was normal, now the patient is having. So I'll do a CT always at the baseline. So besides urine analysis, do a CT, rest depending upon what the dominant clinical manifestation is.
So CT chest and CT sinus also?
Sinus, yes, more so if you are planning a biopsy. Many times, if such presentations are there, to document what these things are. And sinus is one area which you can get a biopsy easily. Although yield is low, you sometimes might have to do I remember in Balmati Devi, we did the biopsy thrice because we didn't have any other manifestation to begin with. But the third one showed a granuloma and a vasculitis in the same biopsy.
And how to proceed for the serology?
Serology, in the beginning, now we only do PR3. We have done away with doing an IAF as such after the international consensus. But if there are facilities available, perhaps it would be better if you can do both. And if the first one is negative, you will do the IAF, the serology with the second kit. If rarely once is negative, second time you might get positive. The third is serial doing a PR3 has got practically not much value. Only one value is that if you have had if you have clear-cut relapse, there is no role. If there is if some patients have where you're doubtful whether it is a relapse or not, there you do a PR3 and initially it was high, it had come down and now it has again gone high, it is just one add-on. But as a protocol for doing it for everybody, I don't think it makes sense. And there was a Manitsan 2 trial also, wherein they tried to do the treatment according to PR3 levels. Either there is a PR3 which had become negative becomes positive again, or there is a doubling of the PR3 titer. But there was a problem with calculating the sample size in that, and they themselves accepted. So in nutshell, I don't think that's a very good strategy to follow. It's not a good strategy. Even the relapses occurred in which there was no PR3 positivity. Even there's no repopulation of B cells. Even in that subgroup, in that paper itself, there were relapses. So we tried it. It doesn't really work.
Absolutely. This is the latest literature also says. And the last question, Aman, when do you go for biopsy, histopathological confirmation in suspected pancreavasculitis patient?
Sir,
you and after you, Vikas.
Sir, the first thing is in a naive patient who's not diagnosed. If, say, for example, the patient comes with full house, like there is RPRF, there are some lung nodules, there is sinus, there is everywhere else. We in a tertiary care center, we generally try to get a biopsy, but in practice, one might get away by doing a biopsy in such scenarios. If everything fits the bill, you may not do a PR3 is positive, everything fits, may not do a biopsy. But say there are no upper airway symptoms, there are some nodules, some arthritis, plus minus PR3 positivity, there is an erythemanodosum also, as I showed. There you might definitely, I will surely take a tissue, maybe do a CT guided biopsy, because it might be Ponson's arthritis in somebody who's got nodules because of TB. And the PR3 is also because of TB. So there you should always do a biopsy. Once in a while, and the other thing is that somebody asks you, we've recently had a patient in another unit where there was there was some arthritis, there was some suggestion of a neuropathy, and there was a nodule. But when I saw the patient, in fact, Pratik asked me to see the patient in IM1, the patient had cytopenias. The platelet count was 80,000. I said, why the hell the patient should have cytopenias in vasculitis? And we said, if it is a CTD spectrum, there was some sicca symptoms. It was undifferentiated connective tissue disease. Eventually, ANA turned out to be positive. ANCA was negative. And a biopsy showed a mucormycosis. So nerve involvement, joint disease, high ESR, but it was not vascular. Nodule was because of a mucor in somebody who was not a diabetic and a young male. So their biopsy is very important. On relapse, even if you got lung nodules, always do a biopsy. As I've said, we've had 3 TB, 2 TB and 1 NTM. And we've had a couple of others and 1 mucor, which... So all these infections might come when the patient is on immunosuppression. On follow-up, perhaps lung shadow, I'll always do a biopsy. Kidney, jury still out. Well, for prognostication, it always helps. If it is patient, especially advanced renal failure, creatinine is high. If it is a fibrotic disease, you can always tell the patient, don't, whereas if it is a crescentic, the outcome is going to be different. If it is sclerotic or mixed, the outcome is going to be different according to burden classification. If it is unusual site like a tumor-like mass or a prostatic involvement, you will always do a biopsy.
Vikas, to finish the talk.
Yeah, we'll always go for tissue diagnosis. Not only because being at the tertiary care center and it's a teaching training center for the residents also, because that is how they will learn also. Because many times, as Aman has clearly pointed out, there are surprises. You will find tuberculosis or a fungal infection or even a malignancy at times. So, and it makes a difference of life and death for that particular patient. So preferably, one should not avoid doing a biopsy from a tissue. Very rarely, if you have some kind of reservation and some problem or not having access to that particular tissue and expertise, then maybe you can take a call. But then it should be taken with the the patient or the relatives of the patient in sort of confidence that this is because of what we want to do this, but it's not possible. If you allow us, we can try out with immunosuppression. Because even if immunosuppression causing infections at a later date, some 6 months or 9 months or 12 months later on, many times I had seen relatives blaming that the initial diagnostic workup was not complete. And anybody can tell them, because they will go for a second or third or fourth opinion, and somebody may say why it was not done at the baseline. And nowadays litigations are very common and doctors are soft targets for everyone. So I think professionally also we need to be...
Sir, 1 minute.
Oh, okay. We are done. We are done. So I think biopsy should be done whenever possible. In all cases, possibly, but only in extreme cases, we may just do away with biopsy where there is some problem or the other.
Sir, we are facing some technical issues.
We are finished. Thank you, Vikas. Thank you, Aman. Thank you, all the audience, for joining this meeting, this wonderful meeting. And I again thank you, both of you, for the excellent presentation. Thank you. Okay.
Thank you, sir.
Thank
Always
you,
a
Aman.
pleasure.
Okay, bye. Okay, Banwari. Thank you.
Thank you, Vikas, sir.